So we have seen the ECGs in acute coronary syndromes after the STEMI management. Now we have come to the final section of the presentation, the prevention of coronary events, prevention of cardiovascular risk, and then let us see what are the steps that we need to take to prevent this disease. Risks for coronary artery disease begins very early in childhood. Plaque buildup develops later in life due to risk factors. CAD is not an unavoidable consequence for all. If the risk factors are controlled, all the CAD consequences can be reversed, including the plaque formation, including the atherosclerosis. Risky blood paves way for plaque buildup. Small, soft, inflamed, lipid-rich plaques with thin walls are the ones which are vulnerable, and they are the ones which rupture. 75% of myocardial infarctions occur in people with less than 25% stenosis. Only 1/3 have advanced warning as chest pain. 2/3 they are caught de novo without any advanced warning or chronic unstable angina. Chronic stable angina, they suddenly have a vulnerable plaque rupture which leads on to acute coronary syndrome. Half of the sudden cardiac deaths occur in so-called healthy persons. They say till yesterday he is very well off, suddenly he had chest pain and died. That is due to fatal ventricular arrhythmias. 2/3 of these sudden cardiac deaths occur before they reach the hospital, pre-hospital mortality. So do not wait, begin heart healthy lifestyle right now and institute the same practices in all your patients. How important is coronary angiography? We know that 2/3 of acute coronary syndromes result from coronary artery stenosis less than 50%. Less than 50% of myocardial infarctions result from coronary artery stenosis of greater than 75%. So it is not the degree of stenosis that is important, it is the vulnerability of the plaque. If the plaques are stable, even if the coronaries are narrow to the tune of 75%, patient may not have acute events, they may at best have chronic stable angina. But those people who do not have sufficient flow limiting stenosis but have vulnerable plaques, they will succumb suddenly due to acute coronary event. Coronary artery angiogram may give a false sense of security because coronary angiogram cannot document the vulnerable plaque or stable plaque. It can only say the degree of narrowing and the flow limitation. In asymptomatic subjects, coronary angiogram is not indicated. Instead, focus on conventional and novel risk factors. Of course, in a patient with acute coronary syndrome, coronary angiogram is a must because early intervention and reperfusion, PCI, plan the treatment strategy, or think of CABG, coronary angiogram is a must. The nature of the plaque determines the occlusion and not the degree of stenosis. Lipid-rich, soft plaques with little small thickness of their wall, of their cap, they rupture and they are the vulnerable plaques. Needless to say, this is the deadliest devil. Women smoking, childhood smoking, chain smoking, they burn their feet, they burn their hands, they burn their hearts. PAD, CAD, CVD, CKD, all are different manifestations of the same disease. The deadliest devil, in addition to cardiovascular mortality and morbidity, tell me what it does not cause in any system of the body. The Saptapadi, Sapta is 7, Padi steps, 7 steps. Screen, define and target high risk patients. Modify lifestyle factors, medical nutrition therapy, physical activity. Explain and persuade to quit smoking and decrease alcohol consumption. Aspirin 75 to 150 milligrams in all those with more than one risk factor. Aggressive control of diabetes, HbA1c less than 7 should be the target. Attain the BP goal of 140/90 in all. In diabetics, it should be 10 millimeters less compared to normal subjects. ACE inhibitors and statins for all diabetics, statins for increased LDL, address decreased HDL, increased lipoprotein A, increased triglycerides, increased HSCRP. All these together will pave way for a healthy heart. The lifestyle change, total lifestyle change. The 6 components of total lifestyle change: medical nutrition therapy, previously called dieting. Nobody wants dieting. If you say it is medical nutrition therapy, what does it mean? SOS, less of salt, less of oil and less of sugars, less of saturated fats. Oils, when we say saturated fats, physical activity, and then weight consciousness. Weight should be less and weight should be less. Stop smoking and decrease the alcohol. Stress reduction and being positive. Control and treat all aspects of metabolic syndrome. CV risk evaluation and prevention at an early stage and periodic follow-up. These are the 6 components of total lifestyle change. Look at some of these quotes. Genetics loads the gun, environment pulls the trigger. Even if you have a loaded gun, if you don't pull the trigger, no harm is done. The trigger are the risk factors. If we control the risk factors, even if we are genetically prone, we may escape the onslaught. This is pronounced by N.S., who is the director of CAD Research Foundation. Just being an Indian places you at a higher risk for heart disease than having high cholesterol or being a smoker. See, smoking and high cholesterol are competing with the racial predisposition here. Indians are at such a greater risk than being a smoker or dyslipidemic. H. Robert Superco, Director, Berkeley Heart Laboratories. A lot of people, they just look healthy, they feel healthy, they don't get tested for heart disease. No, I'm happy, I'm healthy. Why should I go to a doctor? Why should I be tested? By the time some of them find out they have CAD, they are either in an ambulance or in a hospital bed. Dr. A.K. Rao, National Asian Indian Heart Disease Program, has quoted this. Today there is a tsunami of CAD in India. CAD in India has a tsunami now. There is a CAD tsunami in India. The immediate step is awareness of CAD. Awareness among doctors is crucial. Awareness among the public is crucial so that they approach the medical facility at an early stage. Then we need to educate the people at large. Second step is to employ preventive strategies. The key to tackling this tsunami lies in prevention. This is said by Padma Shri Professor Ashok Sheth, who is the intervention cardiologist AIMS. He is the cardiologist who has done almost the maximum number of intervention procedures to date in the country. And he, being an interventionist, advocates that prevention is the key and not opening up more cardiac cath labs and doing more cardiac interventions. Look here, this ape became a Homo erectus, started to be a hunter and gatherer, became a civilized man. All this transformation from the ape to a civilized man took 2.5 million years. This civilized man became so uncivilized today that he never exercises, he never cuts his thoughts for food, and he always in front of a TV or a computer. And in 50 years we have destroyed what we have achieved over 2.5 million years. In no time we have destroyed. Look at this young girl praying the Lord. Dear God, oh, let a miracle happen. Please save my dad or mom from heart attack. Let no one wait until this situation. Before we burn our fingers, before something drastic happens, let us take the lead and prevent these things by altering the lifestyle and modifying the risk factors and controlling the factors that we can control. The rest of it, of course, we will lead to God. So my dear doctor friends, think for a moment. All of you, please apply your mind. Should we not start this campaign from 20s and 30s? Should we wait till we all suffer and succumb? Is it not cost effective and safe to take action now and prevent the disease rather than go to a coronary care unit or acute coronary syndrome with PCI, CABG? What are we waiting for? Whose permission is required to start this process? Who will bell the cat to motivate for CAD prevention? It will never be a priority, I tell you. Mark my words. For our rulers or our patients, they will never take it as a priority unless the acute event comes. They will not wake up. It is we, the doctors, the answerable ones for all, should take the steps to see that every patient who comes to us is screened, properly advised, and preventive steps are taken. So please take a pledge now to screen all patients above 30 for cardiometabolic risk. Initiate them into preventive action. It is difficult, I know. It is not that rewarding either, but persuade, persist with them, and see that whether you can reduce at least some part of the burden of this epidemic of CAD. Grandparenthood, a place called love. Let's all enjoy this beautiful phase of our life. One has to live until that age to keep the health and enjoy the grandparenthood, isn't it? So my dear friends, this is the final slide of my presentation. Of course, there is a next session by Dr. YMC Reddy, who will be telling us about the PCIs and the other coronary interventions in acute coronary syndromes. Thank you all. Thank you for being with me throughout for these lengthy sessions, and I hope I could impart some of the important knowledge and tell you the important principles of management and treatment. Okay. Thanks to everyone. Thanks to the sponsors. Thanks to all the persons who helped to make this CME happen. Thank you.